Okay, why don't we, it is on. Okay, why don't we have our panel come on up and we'll get started. I think I missed the stairs. Okay. Yeah, sorry. I let everyone. Good. Well, first of all, thanks for inviting the Bipartisan Policy Center to be here today. We're super excited to talk to you about what we think are some of the most pressing issues in healthcare. So on our first panel discussion today, we'd like to discuss behavioral health care. And when I say behavioral health care, I'm talking about both mental health and substance use disorder. At the BPC, we've been working on these issues for, I've been there about 5 years, and we've been working on these issues for, since before I got there. The problem is that the problem has gotten worse, and it wasn't good to start with. Just a couple of things that what we do know. We know that that over 50% of people with a mental health problem is 50% not getting treatment. When it comes to substance use disorder, it's about 90%. That's huge. When you bring these problems, and by the way, that was at the beginning of the pandemic. As we all know, things have gotten worse during the pandemic. When you bring that to rural areas, the numbers are even worse. And we know that in non-metropolitan counties, more than half of those non-metropolitan counties do not have either a psychiatrist or a psychologist. This is troubling. So the work that we've done at the BPC has ranged from, we've been looking into behavioral health integration with primary care, and we have, at the beginning of that work, we conducted a national survey through Morning Consult, and one of the findings was particularly interesting. 39% of the people who were receiving mental health treatment were already getting it through their primary care provider. 39%, that was compared to, I think it was 45 or 46% who were receiving it through a specialist, like a psychiatrist, a psychologist, a clinical social worker. So already we know that primary care providers are taking the lead on the behavioral health care for a lot of their patients. Yet, they will be the first ones to tell you that they don't have enough time to do it, they don't get paid enough to do it, and many of them don't feel comfortable doing it. They don't feel like they are sufficiently trained. Yet they are doing it to care for their patients who cannot get care from a specialist, or perhaps it's not even appropriate for them to get care through a specialist. Perhaps they really only need to be working with a primary care provider. The other problem is access issues for specialists. One, because of the shortage of the specialists, but two, because many of them do not participate in insurance networks. And you may have heard the term ghost networks. And we're hearing this a lot more lately because someone is having problems with whatever, either serious mental illness or depression or anxiety. They look in their insurance network and they go down the list of providers. Not taking new patients, not taking new patients, long wait time, have to drive too far, I can't get there. And so this is one of the issues that we have been focusing on as well. So to get enough behavioral health specialists up and running to really fill in that pipeline of people, it's going to be hard, it's going to take a long time. We should be focusing on that, but in the meantime, we should also be focusing on how to make the best use of our existing workforce. And that's where we keep coming back and back to behavioral health integration. Behavioral health specialists working together in consort with primary care providers. Now, what form that takes? We think it's going to look different in different places, and that we ought to be meeting providers where they are. And this is something that I'm going to ask the panel to talk more about. So let me stop there and introduce our panel. We've tried to bring this panel together so that you have a mix of national experts and more regional experts. So let me first introduce Andy Brown. Andy is the Commissioner of Behavioral Health Services at the Kansas Department for Aging and Disability Services. Welcome, Andy. Kiley Floyd is the CEO of the, make sure I pronounce, Nemaha? Okay, Valley Community Hospital. Eric Thomason is the Vice President of Behavioral Health and Addiction Treatment at the Community Health Center of Southeast Kansas. It's a federally qualified health center that practices integrated care. And Vikki Wachino is Principal of Viaduct Consulting. Vikki advises mission-driven healthcare organizations. From 2015 to 2017, she served as Deputy Director of the Centers for Medicare and Medicaid Services. That's a part of the U.S. Department of Health and Human Services. And Vikki also served on the Bipartisan Policy Center's Behavioral Health Integration Task Force, which produced a report a couple of years ago. And you can certainly find that on our website along with all of our other reports looking at implementation of the 988 crisis response line and the use of unlicensed workforce such as peer support specialists and community health workers. And we're about to come out with a report in the next couple of weeks on how to implement behavioral health integration in rural areas. So you can find bipartisanpolicy.org. You can see all of our reports. We're going to start with a discussion among the panelists, and then we're going to turn it over to you. We're going to leave plenty of time for you to ask questions and to have a conversation. So Vikki, let's start with you. Let's start with the big national perspective. So for those who aren't terribly familiar with behavioral health integration, what does that mean? What does it look like? And how does that vary? I had said before, we want to meet providers where they are. So it can look very different, but what are we talking about here? Give it just a moment. It took mine a moment to kick in. Okay, let's get a little help here.
Okay, better?
Good.
Thanks, Marilyn, and thanks to the Sunflower Foundation and Bipartisan Policy Center for convening this forum. It means a lot to be here and to reflect on Senator Dole's legacy, which certainly, for many of us who've been involved in public service over our careers, like he was the beacon of service to country. And thank you as well for organizing a Kansas-focused discussion. A number of us had the opportunity to visit Douglas County this morning, and as someone who works in the national level, thinking about how you expand access to behavioral health services, it was incredibly heartening to see Douglas County putting it all into practice in such a meaningful and high-impact way. When I think of integration, I think of two things. One is, and this is somewhat borrowing, Marilyn, from your phraseology, I think of it as meeting people where they are, overcoming some of the access barriers and bringing services to people where they are going to present otherwise, including primary care, but not limited to primary care. And second, along with that, making services seamless to people so that their experience of the services that they receive feels integrated to them, which means breaking down silos between physical health and behavioral health, and so that their experience is a high quality one and they're being helped to access the services they need. We look first to primary care because that is where so many people go to meet their panoply of health needs. The challenge that we have historically is that primary care, and not just primary care, but healthcare generally, has not yet fully embraced the mission of delivering behavioral health care for all kinds of perfectly legitimate reasons. As Marilyn says, it is not easy. Primary care clinicians are not trained as behavioral health providers. They are, in many cases, reluctant to take on those responsibilities. But here's where integration comes in. Integration comes in helping that primary care clinician access the expertise that he or she needs to deliver to the patient. And there's all kinds of modalities through which that could take place. It could be a consultation, it could be a referral, it can be bringing people on a team into the primary care clinician's office to actually meet that person's needs. And that's probably the fullest expression of integration, is a team-based approach where the team, the clinical and non-clinical workers, are thinking about all of the patient's needs holistically. And why do we want to do that? Well, first, as Marilyn said, we've got very significant access challenges, and these are not new. We have had these for a long time. But here's what is new, is we just have very rapidly growing behavioral health conditions in the United States of America. And if you look back over the past few years, you would see that sometime in 2011, rates of kids' mental health conditions started to go up. It's not a pandemic phenomenon. 2011 is the year, not 2020. We've seen rates of opioid overdose deaths increase significantly, and our national suicide rate is increasing significantly. And troublingly, it's growing fastest in rural areas and among Native populations. So there's an urgency, I think, around behavioral health integration, but also kind of a need to double down, because we've been working in integration for quite some time. We are not there yet. The last thing I will say is I think there's a case for thinking about integration beyond healthcare. I think it is essential that behavioral health be integrated into healthcare, but if we're really going to meet people where they are, we need to be thinking about how to bring those services into a range of settings. Schools, meeting kids where they are. Almost every kid in America goes to school. Many of them go to public schools, and there's kind of new energy and commitment to delivering health and behavioral health services there. And of course, as kids are recovering from the pandemic, and by recovering I mean not from COVID, but from isolation and from school disruption, I think there's a real case to be made for meeting kids where they are, and where they are is in schools. I think there's unexplored opportunities in Head Start centers. We've seen some interest at the federal level in trying to expand access through settings like libraries and through farm assistance programs. So I'll offer to you the opportunity to think about integration very holistically in both healthcare and non-healthcare settings.
So before we move out of the national space here, can you talk a little bit about the mood in Washington? Because it almost, that could mean anything, and so I'm not surprised that evoked a chuckle. But as it relates to the desire or the appetite to do something in this area right now?
It's such a great question, because you give me the opportunity to say, as I think everyone here probably has their own take in the mood in Washington. But when it comes to behavioral health, like, put aside your assumptions. Because what has happened in DC over the past few years is a very strong degree of bipartisan commitment to making progress on this issue specifically. So it crosses parties, and it also crosses Congress to the administration. And it's very hard to point to other issues on which that is the case. And I'll say, I mean, Marilyn mentioned that I was on the VPC's Behavioral Health Task Force, and I hope Marilyn and Bill don't mind me lifting up the tent on that just a little bit. So cross-sector, bipartisan leaders, very little, if any, debate over the need to move forward on a bipartisan basis. It was kind of remarkable. Whenever you go into one of those kinds of conversations, you don't really know how it's going to roll, and it rolled really, really nicely in terms of like everyone rolling up sleeves and being productive. More important than that is that on the Hill, people rolled up their sleeves to be productive last year. And you saw, particularly in the Senate, but also in the House, the Senate assigned bipartisan teams on specific topics: workforce, kids, integration and coordination. And a lot of their proposals moved forward in two pieces of legislation last year. The first was the Bipartisan Safer Communities Act, which was gun safety legislation that moved forward after Uvalde, Texas. And the second was the Omnibus Appropriations Bill last year. So we had two pieces of bipartisan legislation move forward last year. So I think, I mean, to the legacy of Senator Dole, it is possible, right? Even in this very challenging environment to move forward, it is possible to move forward specifically on this issue. And the result of this were things like very significant investments in grants for workforce development. And I'll be stunned if we don't hear from our other panelists about some of the workforce challenges that exist here in Kansas and elsewhere. New investments in certified community behavioral health centers. We saw some of that being put into practice in Douglas this morning. And a very big commitment to schools. New policy and new resources to encourage different federal agencies, education and health and human services, to collaborate to build the capacity of schools to provide health and behavioral health services. So good progress, and I will also note that underlying all of that are the fact that many more people in the United States than at any time of our history both have health coverage and with it have access to mental health and substance use benefits because of the accomplishments of yesteryear, which were the Affordable Care Act and mental health parity.
Yeah, I promise I'm going to get to the three of you just momentarily, and please chime in whenever you'd like. But to mention a couple of other important things that happened at the end of last year. Congress did add Medicare coverage for licensed mental health counselors and marriage and family therapists. This was an important step because we need every provider we can on the ground getting paid to provide services. The other thing that happened is the administration took some important steps to try to close up some loopholes in network adequacy rules. Again, I was talking about these ghost networks, and so this was a start. They haven't done everything that they need to do, but it was definitely a start. The other thing that happened is Congress extended for 2 years the telehealth flexibilities that it made available during the pandemic. So it extended those for 2 years. This is super important as it relates to mental health and substance use disorder because there were a lot of new people who weren't getting treatment before, all of a sudden getting treatment during the pandemic for mental health and substance use disorder. Okay, Andy, let's turn to Kansas. Can you help us to understand what the need for behavioral health services is here in Kansas? How great is the need? How are people currently getting services? What are the limitations and barriers? What does the current situation look like here in Kansas?
Well, if you're familiar with the MHAH survey, we have the distinction of being 51st in the nation when it comes to behavioral health. And hopefully that'll just be a blip, and we'll move up the ranks again when the next one comes out. But a large part of that is due to our workforce shortage. We have 105 counties, and I think 99 of them are professional workforce shortage areas. So, you could, if you assume that like 1 in 4, 1 in 5 Kansans has a mental health issue that needs treatment, the idea that we're going to have enough providers in our state to meet that need is just a fallacy, right? It's not going to happen. It's not realistic. And so there's a tremendous need for us to look at how we can make better use of access to services so that people can get what they need quickly. Looking at what we can do to emphasize evidence-based treatments so that those treatments are efficient and successful. And then also really looking at how we can expand those treatments beyond the traditional professional workforce, right? And so there's a real need for us to focus in on things like, how are we using peer support? Making sure that, when we need somebody to do clinical work, that we're using that clinical person at the top of their license so that they're not using their time for things that people at a lower level of licensure can do. And we also want to make sure that we're finding ways and opportunities for those people that are at the highest level to be able to consult with our primary care folks so that the primary care folks feel comfortable prescribing and treating mental health disorders or behavioral health disorders. Kansas has had a long history of sort of segregation within our behavioral health programs, right? So even within our behavioral health, our SUD providers and our mental health providers are oftentimes separate and distinct, both with licensure and with practice. And so we've been working to overcome that in a lot of different ways. Recently, we moved forward as a state with our CCBHC expansion. Kansas was, I think, the only state that was not a demonstration state that has made an attempt to implement CCBHC statewide. We're about halfway to our goal of doing that. We'll have 20 of our 26 CCBHCs provisionally certified July 1st, and then we'll get the rest of those in probably by January 1st of next year. And that provides us with the opportunity to then start looking at, how are our systems and our billing structures within Medicaid able to adapt and support behavioral health integration and primary care. We'll also be able to look at what we can do. You mentioned schools. We have a pilot program that has now gone on for about 5 years and is very popular in the legislature. Yes. So it's a mental health in schools program, and it allows for the schools to bring in behavioral health support to be physically in the school and able to respond to kids that have treatment issues or a crisis that comes up. And so it's a very effective tool, but it's also something that we have a lot of sort of territorial things that go on with it, right? So we're always kind of balancing the fact that we have a limited workforce, and we want to make sure that when we bring our resources to bear, that we're really trying to make sure that the person who's most able to respond to the majority of those situations is in those facilities and able to respond to that need, so that your higher level folks can be doing the other types of work that need to be done to support those individuals, and make sure that our prescribers aren't tied up with other things. We've been using a lot of telehealth to get out to our rural communities. There's a lot of need for us to provide psychiatric support via telehealth, so that in our rural areas, our doctors and nurses can feel comfortable prescribing things after they've had a consultation, or after there's been a screen that happens via telehealth. And it really is, I think it's just a challenge that we're going to face, and I think other rural states face it as well, that if we like you just said, if we don't meet people where they're at, right, with the resources that we have available, and trying to maximize that in a way that everybody is able to get access to care, right? We're going to continue to have people that are showing up at the highest level of crisis. We're going to continue to have those negative outcomes that we're tracking. And so when we look at where we have the most difficulty in Kansas, it's oftentimes in those rural and frontier areas where people have to travel for hours to get services, or they have to rely on access to telehealth.
Andy, how does Medicaid factor into this? What is the role of Medicaid in providing care?
So Medicaid's incredibly important. Kansas is yet to be an expansion state, but it is still our primary payer for the majority of children that have behavioral health issues. And it's still our primary payer for anybody that has severe and persistent mental illness. So it's incredibly important that our Medicaid policies and procedures allow for funding to be used for integration, and that we create ways and means for us to make sure that the reimbursement rates for those various codes and things are supporting workforce development. Obviously, I'll stand up because I'm representing Kiley administration today too. Like, we would love to have Medicaid expansion in Kansas because it would help us. It would help our rural hospitals. It would help our FQHCs. It would help our CMHCs. But our safety net relies on Medicaid. And so finding ways that we can maximize that to support our workforce development is very important.
So Vikki, you've been in the leadership side of Medicaid from the federal perspective. Of course, Medicaid is a shared program between the state and the federal government, run by the state. Are there levers, or what can the federal government do to potentially support, or what can we do from the federal side?
Well, to your earlier question to Andy, and also your observations about some of the actions that have been taking place recently in the policy front, the strongest way to advance behavioral health service provision or healthcare service provision generally is through insurance coverage. Medicaid, Medicare, commercial insurance. And as important as grant funding is, or CCBHCs are, to efforts to expand access, having people have access to mental health and substance use benefits is the best way to connect them. It makes them very portable. You can get your coverage, get your services where you want to if everything's working okay. And so it's really important that Medicaid, Medicare, and commercial insurance have all of their oars in the water to be pushing towards integration, if integration is the goal. I think we have seen good progress on this from the administration and from Congress. There's been a greater emphasis in Medicare on team-based approaches, and that is a very big step forward. Medicaid has been encouraging integrated payments specifically for kids. So there's good progress. I will say, just to Andy's point, I think for Kansas, the missing piece is Medicaid expansion. And I know it's been a difficult conversation here for some time, but the single biggest thing that Kansas could do to improve its behavioral health system is Medicaid expansion, because some of the lowest income people in the state, some of the people most at risk for developing serious mental health conditions are going without entirely. So we've got some opportunities through that to advance prevention and connect people to services that can improve their health and lives for decades to come.
Okay, Eric, you're the guy on the ground.
Yes.
Tell us about your program and why does integration make sense here, and what does it look like at your center?
Yeah, so Community Health Center of Southeast Kansas is a federally qualified healthcare center. We're one of the largest in Kansas. We serve 9 counties. Most of them are rural counties, if not all of them, maybe frontier. And like many of our partners in the communities, we have workforce shortage issues. FQHCs, for those who don't know, were kind of created as this idea to be a safety net for people who otherwise wouldn't be receiving equitable health care. And so that's how we started in 2003. Very quickly, I think it was 2005, we added our first behavioral health clinicians. Like much of Kansas, we struggle with provider recruitment. We also have underfunding of our community mental health centers, which is a challenge for them to grow their programs. And so naturally, as the safety net, we kind of identified we need to have a greater role in behavioral health care. So there's a lot of different ways that that get called integration of behavioral health care. Really, the two concepts are co-location and then behavioral health integration. And so co-location is something, of course, that we do, where you hire behavioral health clinicians to work under the same roof as your primary care and medical clinicians. That is a decent model. You can have warm handoffs. You can do a variety of those things. That's better than having two separate organizations, in my opinion. However, the concept of behavioral health integration can actually work both ways. We're going to talk a lot about behavioral health benefits, but there's also been well-documented medical benefits of providing behavioral health integration as we think about the assessment of hypertension and the interventions for hypertension and comorbid anxiety and all this other stuff. But for us, what it looks like is we have a primary care clinic. We'll just talk about our smaller one in Baxter Springs, Kansas. So we'll have 2 to 3 family nurse practitioners working at any given point in time, seeing your classical rural behavioral health or primary care complaints, which could be anything. Right? Like it could be, I'm here for a medication check for my blood pressure, or I'm walking in and my arm's like hanging off, right? And they want surgery down in a rural clinic. And then throughout the course of the day, we have a trained behavioral health clinician. It is a licensed specialist clinical social worker, and that's important in the FQ world, who will actually go in and interact with the patients really regardless of their complaint, right? So the idea is, or some organizations have attempted to use like the PHQ-9 being elevated, so the depression screener, or the GAD-7, which would be an anxiety screener, and they would use that as a trigger to get the behavioral health consultant into the primary care exam room. So our preference is we don't do any of that. Our preference is our behavioral health consultant just plans on going in the room and doing just a warm check-in. And so an example in this moment would be like, hey, my name's Eric, I'm a behavioral consultant with CHC, how are you doing today? Right? And we have that conversation with the patients in an attempt to kind of to normalize the idea of, one, I'm talking to a behavioral health clinician, which can kind of be weird, right? And 2, I'm just here for a hypertension check-in, and this guy came to say hi to me. So maybe next time when I'm depressed and he comes to say hi to me, I'll answer appropriately and really share the way that I'm feeling. And so throughout the course of the day, our behavioral health consultancies are brief interventions. Most of the time, they take about 7 minutes. In the billable world, that's not a billable visit, so we don't bill for it. But it is an opportunity to have a conversation with a health clinician. Why it can be potentially beneficial is I'm a psychiatric nurse practitioner by training. I'm trained to medically interview patients, right? My social workers aren't. They're trained to interview them in a separate way from a behavioralist perspective. So when we think about the management of hypertension, we can objectively see that a blood pressure is elevated, right? And hopefully the medical provider would ask, are you taking your medicine? Right? Sometimes they don't, believe it or not. But a behavioralist, they may say, are you stressed? What's going on in your life? I understand that you're having difficulty exercising. Let's talk about some things that you can do to make that easier for you. And so we talk about behavioral health integration, behavioral health co-location as something that's beneficial for all of our patients with reduced access to care. But it can also be incredibly beneficial for the medical side of things as well. And one of the greatest barriers from us being able to implement this more widespread throughout our organization is actually reimbursement. We've got a wonderful relationship with KU Social Work and their outreach through Pitt State Social Work. We can hire plenty of social workers where we're at.
Clinical social workers?
Huh?
Clinical social workers?
Well, so they start out as IMS, and part of employment with us is we cover the cost of clinical supervision because I guess I'm up here today, so I'll share this unsolicited opinion. So you're welcome. The idea of creating more LMSWs is going to help the mental health centers, especially under the CCBHC reimbursement mechanism, because they will get PPS funding for that group of patients. It'll benefit us because we're going to help them get their clinical social worker degree or their certification, and we're going to have a service agreement associated with that. So that means they're going to be employed with us for 2 years, and then we'll get them for an additional 2 years, and then we'll get PPS. But really to work towards solving the mental health crisis that we're facing in Kansas, we need independently licensed clinicians. We need clinicians who are able to open up their own private practice. Because believe it or not, people who have private insurance suffer from mental health issues. And I know that comes as a shocker, right? So as far as I'm concerned, I will gladly take every uninsured, Medicaid recipient, commercially insured, doesn't matter to us, we will take everyone. But what we need is we need more private clinicians taking insurance to provide services. And we're not going to solve that problem by not getting our people clinically certified. So I think every organization, we owe it to the state of Kansas, we owe it to our community members. Every single one of our behavioral health clinicians who exit school, we should be providing clinical supervision as a part of their employment to get them clinically licensed, so then they can leave my organization if they need to or if they want to. My hope is that they stay with us. And we've done a really good job keeping clinically licensed staff. And to your point, Vikki, we were one of the first organizations to offer behavioral health services in jails. We have a very large school-based behavioral health program. We had 11,000 visits last year. And so we are trying to meet folks where they may be.
So you've talked about the difficulties with reimbursement. You've talked about, I've heard workforce so many, if I could have counted the number of times I've heard the word workforce over the last 2 days since we've been in Kansas, and it's not surprising. You've talked about bringing people along who are employees. How are you getting the right employees, and how are you training? How did you start this, and what did you do to get your staff where it needs to be? And what are the barriers that you've faced along the way? How did you implement?
Yeah, so I think it was a decision by leadership before I got there. I won't take all the credit, right? So we have a wonderful CEO, Krista Postai, wonderful president, Jason Wesco. And Krista was the original founder for CHC. So if you don't know this lady, please take time out of your schedule, reach out to her. She's a wonderful human. But we just made a decision in 2005 when we recruited our first behavioral health providers that we were going to maximize our behavioral health providers. We were going to get the most out of the dollars spent by our Medicaid payers, right? And that's incredibly important to us. We have great relationships with MCOs because we stretch that dollar and maximize the outcomes that you get from it. So it saves taxpayers dollars, hopefully. But we made a decision, and it was part of our core values and our mission as an organization, which are incredibly important to us. We're led by an incredible, innovative board, and we recognized very early the need for improved access to behavioral health care, even if that's outside of us. And we really bought into that, and I think people should know that I ran the math on how much it actually costs to get an LMSW to an LSCSW. And if you just want to look at hours cost, about $15,000 with the amount of required supervision that takes place. If you want to look at missed revenue costs, $45,000. That's how much we are asking our organizations to pay or miss out on to help get these people to clinical licensure. But it is worth it every single time, because what we have found, and so I've been with CHC for coming up on 5 years now, we've had one clinical licensed therapist leave CHC. That's it. And she opened a practice in Pittsburgh, Kansas. How much of a win is that? We recruited her from another area in the state. We got her to Pittsburgh, Kansas. She got her clinical licensure. She left and she opened a practice where we live and practice. That is a win, because we know people are still getting access to healthcare. It's not about us. We are a vessel to help get that stuff. But I think from a funding perspective and a staff recruitment perspective, those are the things that we need to be thinking about, and those are the conversations we need to be having. I don't want to recruit all the providers from the mental health center, right? Because I'm just taking from an organization that needs them, right? So it doesn't benefit our communities. We are a community-driven organization, not a caseload-driven organization. And I think that's a shift that we need to embrace as healthcare leaders in Kansas.
If someone asked you whether your center is successful, what's one data point or one piece of evidence that you could tell them that would help to demonstrate where you've had impact?
Oh gosh, hearing stories about our kids growing up. I think for me, it's stories that really carry the greatest weight. I mean, we can talk about numbers, like we saw 43,000 patients last year, and we're not a behavioral health center, right? But we're one of the largest mental health providers in Southeast Kansas. We 11,000 kids. Our local school districts use this software called Panorama. And that tells you academic and behavioral outcomes of our patients. Kiddos that are engaging in our school-based behavioral health programs have a better panorama scores after their year of service. And so I think to point to those, but I think the incredibly important thing is to talk about the times where we're still failing, right? And so last Friday, you get the call that you hate, right? We had a senior at one of our local schools die of a fentanyl overdose. He was found by his mom as she was going to wake him up for school. And that's the stuff that drives me crazy. Because as much as we talk about behavioral health integration and to Commissioner Brown's point, how addictions and behavioral health can get segmented. I grew up in Missouri. I did all my training in Missouri. It was not segmented in Missouri. And we still have barriers in place, like who are we going to fund to provide mental health services? Not us, not an FQHC, but we're really doing the work. And we've got great people, and we still have bad outcomes. And I think that we should always be reminded that we may do a lot of good stuff, and we have fancy lunches and beautiful venues. But the reason we're doing the work is for the community people, and there's still people that we fail every single day.
All right, so Kiley, that's a good entry point for you. You're the CEO of a community hospital.
Right.
And
Critical access.
Sorry?
Critical access hospital.
Critical access hospital. So help me to understand what this looks like on the ground for you and what you are seeing at your hospital, and how you all are working also with primary care providers to address these issues.
So we were fortunate to have one of our doctors go through a fellowship for integration of primary care of behavioral health into the primary care. And it was a train the trainer a few years ago. And she brought back several models, and we've kind of tried to figure out where that fits best for us. But finding the providers is a huge issue. So we did have a licensed marriage and family counselor in our rural health clinic. And this is really, I think, where we found our comfort area. We are not equipped to deal with the crisis, the suicide attempt. That goes through our emergency room, unfortunately, and it has to be referred out.
But how much of that do you get in your ER?
Not as much as we used to. It still happens. So we're really focusing on hitting in primary care before it gets to that level. So those warm handoffs. When we had, so our therapist went into private practice, and she's very successful. So we really try to hit it when there's a new chronic disease diagnosed, or a cancer diagnosis, or you just had a baby, or just life happens. You got a lot of kids going on, and our therapist would check in, just like you described. It's exactly how you described. Just check in to become that reference, to become that person that it becomes comfortable talking to. Maybe it's 5 minutes today, but the next time you see them, that's an hour and a half conversation. And we just want that to be a regular part of your visit. That's just that you're fine where you are. And we talk a lot about meeting those people where they are. For me, telehealth might not be the answer. I might not be comfortable with that. So we need that person. On any given day, I can keep 3 therapists busy all day long in our clinical practice. I can't find one, so I'm going to be calling you.
Yeah, please do.
But it's not always the crisis intervention. We really need to get there before we get to that crisis. Reimbursement's a huge issue. If we could get some reimbursement for the master's prepared, the licensed master's prepared social workers, that would help. And just access in general. I think that we have a pretty robust practice in the way that we're addressing behavioral health, and just making it part of our routine and not making it the exception, or, oh, we've got to refer this. And also, if we identify a problem, we do not ask that patient to leave the clinic for their evaluation. It's an iPad. You know, you can do that in my office, you can do that in the clinic. So we make sure we address it right there. And our providers get a little antsy sometimes because we're taking up rooms. You know, that's a shift also. But I don't want that patient leaving the facility until we've made that handoff or we've made that connection or we have a safety plan. Whatever that needs to be, we need to take care of it right now. And because if you try to get placement in a hospital right now, it could be 2 weeks from now before a bed will open up. That's, you know.
You mean in a psychiatric hospital? Okay, so what happens if you can't get into a psychiatric hospital? They sit in your hospital?
Not always. It
No?
depends on if they have something. If you're truly no indication that you're going to self-harm or harm somebody else, we try to develop a safety plan. And then there's somebody constantly reconnecting with that person to make sure that, you know, we haven't gone to that next step. But, and I don't think I'm exaggerating. It can be 2 weeks, right?
Yeah, absolutely. So we've had calls with some of our local hospitals, and they receive crisis services from the mental health centers locally. All right, so they receive a crisis screening, but the mental health centers don't have the capacity to actually provide an intervention. So these patients will be identified as, yep, you need to go to the hospital, right? And you're going to sit here for 3 weeks, or exaggeration. We've had 4 to 5 days where they can't find a bed. So it was really interesting because the question was, how do you help us with transportation? You're a federally qualified healthcare center, and you're a transportation, KDOT transportation center. So how do you help us with transportation? And my president, very insightful guy, invites me to this call. And I'm like, why the heck are you inviting me to the transportation call? Like, we're all busy. And I hear the suggestions for help, and I said, you guys don't need a transportation department. You guys need somebody who can actually provide an intervention to these people who are sitting in the ER.
That's exactly right.
They don't need to be screened. Let's start them on a medication and reevaluate them, right? If they need to go into the hospital today, okay. But if you're going to hold on to them for 4, why don't we get you started on medicine, right? Consult liaison work, this is done all over the country. This is nothing new or fancy. It's just nobody's really doing it right now.
So we do have to hold patients occasionally if there is some risk. But again, that can be a long time. And there's a struggle in the state about how we're reimbursed for that. Because we are taking up, it's a lot of staff time. Sometimes it's one-on-one nursing care, 24 hours a day. If you can't find a sitter or a family member or whatever that is. So reimbursement for us is a huge issue. But also just having the staff. And I think that in our facility, we have the right mindset. We know the significance of this and the impact of the mindset on the physical health. I think that we're on the right path. We just don't have it all put together. And Northeast Kansas has a tremendous amount of resources for us as we try to work together on this, the Sunflower Foundation being one of them. And so we have the plan, we just don't have it all together. And we're definitely committed to this. Yeah.
So your primary care clinicians, if they can't always find a full referral to a behavioral health specialist, can they get a consultation so that they can handle it? Is it always available to them? How do
Not
you do that?
immediately available. Many times we have to sit on that patient for a while. I have a tremendous social worker who is excellent at this. Not all of my providers are really comfortable with it, some more than others. Our advanced practice clinicians are definitely not comfortable with it. And in rural medicine, that's a lot of the care. So it's a struggle.
So can they pick up a phone, get a consultation with a specialist? How do they do that? If I'm a primary care provider and I have someone who needs something and perhaps I don't think they need a full referral, or perhaps a referral is not available to a specialist, how do I get that person to be able to access a consultation with a specialist saying, hey, I've got a patient who is dealing with X, would this medication be appropriate, or how?
They can make the call, but it might be a while before they get a call back.
Okay, so that's when you're saying you're holding people.
That's when we're holding, yeah.
Okay. What else, I'm curious from the others, I don't know whether you have anything to add from the FQHC perspective on what the primary care providers need.
Yeah, so I think just to clarify a billing point, one, to answer your question about who do they call, they call me, or they call one of our other 45 behavioral health clinicians that we have at CHC, but we are incredibly lucky to have that, and we have really good academic partnerships to help get people here. We also created a postdoctoral fellowship. This is an opportunity to bring psychologists that need 1 year of supervised practice. So it's a way for us to affordably recruit psychologists to Southeast Kansas. But in regards to billing, CMS requires a detailed treatment plan when you're offering behavioral health services, right? So if you see a therapist, for those who haven't, they actually have to put together goals and how you're going to get to those goals accomplished and a timeline for all that stuff. And really hard to do in a 15-minute behavioral health consultant visit, right? So there are actually 2 behavioral health integrated codes, but in Kansas, they can only be billed by PhD and PsyD trained psychologists. They can't be billed by LSCSWs, despite them being a PPS provider in Kansas. So it's already hard enough to find these unicorns. Now you're asking me to find a unicorn with stripes. And so not only is it a workforce issue, but it's also what will be covered by Medicaid issue when we have a PPS provider doing the service, but not getting compensated.
Is that a state thing or a federal thing?
So that's a state thing. So I've actually worked on forming some relationships with folks outside of Kansas just to hear what they're doing. And they don't have these regulations. So whenever you're doing a behavioral health integration code and say the primary intervention is based on hypertension, right? So think back to the motivational interviewing, alternative interventions, psychoeducation that's provided to the patient by the behavioral health consultant. You can't bill, an LSCSW in Kansas can't bill on the hypertension code. They will not get reimbursed for the hypertension code. A psychologist will, PsyD or PhD, right? So then, if they're doing behavioral health consultant and say it's depression with hypertension, if they try to bill for the depression, and we get audited by CMS and we don't have a treatment plan done, signed, the whole 9 yards, that's a problem. And it's a risk. And so we're not going to commit fraud. And so we never billed for any of that because we weren't getting reimbursed anyways. And so that's one of the things that prohibits the growth of behavioral health integration in the state of Kansas, is some of those limiting factors.
Vikki, I don't know whether you know the answer to this, but how does that square nationwide? I mean, is this a common issue?
I'm not sure, actually. It's kind of the first time hearing of it. I will say, just to the point about the e-consults, that's a place where Medicaid has pushed forward just this year to clarify that can be paid for, because they wanted to expand access and because they wanted to incentivize this kind of integration.
Yeah.
Okay.
So I would just
ahead.
go ahead and add that, like, when you're thinking about these, like integration as primary care providers providing behavioral health services, right? There's not a limitation on what the primary care person can bill.
No,
So-
right, it's the specialist, it's the.
Right.
Correct.
Right.
Yeah. So it's not limiting integration in the sense that if we teach our primary care physicians to treat behavioral health issues, they'll be able to bill those.
For the physicians, for the primary care provider's visit,
Right.
but not for the consultant.
Right.
And that's the challenge. So not for the consultant, which is an FTE, salary, benefits, fringe, whole 9 yards.
Right. Anybody else want to weigh in on that, on what we can do in the way of consultations?
Well, I mean, what I would say is that with our Medicaid system, right? When we're looking at how are we reimbursing people for the work that they're doing, right? FQHCs are uniquely positioned because they can do cost-based reports and get their PPS, right? So you can build those consultant positions into your overall cost report, and that goes into your PPS rate for your encounters, right? Similarly, like with our CCBHCs, there's an expectation that they're going to meet all those requirements that you were talking about with regards to, making sure that the charts are completed and that there's, evaluations and assessments and all those things are in there, right? So you're not going to walk into a CCBHC and get a 15-minute, like, hey, how you doing talk. You're going to get, you're going to get those screens, you're going to get the risk assessments, you're going to get triaged, you're going to end up being put in a level of care, right? And so that system is still very different from our primary care system. And, I think it's important that people have access to care. But I think it's also important to understand that, like, the expectations are different. And our primary care, like, we really have the ability to prescribe medications and help with that. We have the ability to do screens. Those are all things that primary care can do today in our system. If we can get to the point where the providers themselves are comfortable doing that work.
Folks, I'm going to ask one more question, so get your questions ready because you're going to have a chance in a minute to ask the panel questions. One of the barriers to integration that we haven't talked about is information sharing. There are very specific and careful rules about what kinds of information can be shared about a patient due to privacy concerns. So I'm wondering how you deal with that. How does one get around these information sharing? How do we information share?
Well, so one potential way to do that, right, is we use our HIE, our Health Information Exchange, right, to document what's going on with patients. And then that information can be released by the patient to another provider. We also have the ability to establish care coordination agreements, right? So that there's something in place between a provider and another provider, where if there's services that are part of that treatment plan, that those services can be coordinated. So there's a lot of ways to do it. The trick is to make sure that you've got consent with the patient to do that workaround.
Okay, on the ground, Eric?
Yeah, so at Community Health Center, we have a shared consent for behavioral health and medical. We also use the same electronic medical record, which makes it very easy for us to, with permission of the patient, access certain files. We do have the ability to mark files confidential that nobody will have access to, except, of course, for the patient or the clinician participating in that evaluation. And then with compliance for 42 CFR, which applies to our addictions work, all of those visits are considered confidential. And so the way to work around that, if you're the patient, is you can request your own medical records, of course. We view medical records as we're the keepers, but the patients are the owners. So,
Yeah, I really don't think that's a problem when it comes to seeking care. And we have a common medical record, and care coordination's huge. So as long as you have those vehicles in place, it hasn't been a barrier for us.
I do think there's an opportunity at the national level to drive progress on medical records, specifically for behavioral health providers. In 2009, Congress made a major investment in healthcare providers' ability to build electronic health records. And we're still working through some issues with that. Not everyone has the same system, et cetera. But we left behavioral health providers out of that. And so behavioral health providers are not on even ground with healthcare providers and being able to share information. So I think if
So
we
they're
wanna
not, they're
get-
essentially not using electronic
Yes,
medical
in many
records.
cases. Some of them are, but they've made their own, investments in it, and it's an uphill climb. And a lot of behavioral health providers in the country are small and don't have easy access to capital to make those types of investments. So I would love to see Congress take a do-over on that issue and make some specific investments in the ability of behavioral health providers, as well as long-term care providers who also didn't get the opportunity on the first round to invest in some of that EHR infrastructure so that providers can talk to each other more easily.
Okay, questions? Questions in the audience? We have it all figured out?
One thing I do want to bring up is, I think for primary care, how we train our staff to address people, not necessarily the clinicians, but my registration staff, my housekeepers. For our facility, all staff members have mandatory education for the QPR and also for mental health first aid. We just recommitted to zero suicide. So we make sure that everybody in the building, if they see something happening, know where to refer that patient, how to respond immediately. We do a lot of retraining on that, and I think that's so important because every one of us has that opportunity at any given time when we're talking to a patient. And that's something I talk to my peers a lot. I think that's really important. We have resources to do that, and we need to pursue it.
Okay, I think we had a question right here in the front. Do we have microphones? Oh, question here. Let's do it here first.
So thank you all very much for your time today. I agree that we have fantastic primary care providers at the APP and MD-DO levels in our primary care clinics in Kansas. I know when I go to see my primary care provider, I have a certain amount of time that I get with her. And if I bring up the fact that I am struggling with anxiety, depression, etc., I'm now pushing her. If I go in to tell her that my head hurts, I'm having migraines, and then we start down the discussion about depression, anxiety, other things, I'm pushing her schedule. So I wanted to revisit that idea that we ask our primary care providers to be the ones that are prepared to do this, and I really am just struggling with that. So can we revisit that a little bit?
Well, I'd say what's stopping you from just setting up an appointment with your primary care provider to talk about your anxiety or your depression?
What's stopping most people from that?
Right.
Yeah.
There's lots stopping most people.
Yeah.
And I would push back that most of our primary care providers would say that when someone comes to talk about an issue, often they're not going to say it's because of, depression, anxiety, or other things like that. They're
Yeah.
And I think that's the beauty of treating the PHQ-9 like it's a vital sign, right? When I was in nursing school, that was during the big push of pain is the fifth vital sign, and now we have this opioid epidemic, right? But yeah, right? But if we treat depression as if it's blood pressure, and we check it every stinking time, the burden doesn't fall on you as the patient. And I also, I get there, I get your perspective when I see my primary care doc, but also I'm sorry that happens to you in healthcare. And that's a failure of healthcare to an extent, because part of my role at CHC is I educate our primary care team on that exact stuff. How do you have therapeutic conversations with your patients? How do you normalize administering a PHQ-9 without blowing it off? Right? I think those are the important things. And for those who may not know on the clinical side, you can also administer a PHQ-2, which is literally 2 questions. So there's no reason why we can't be screening adequately for depression. And I think that's one of the beauties of the CCBHC model and the FQHC model, is part of that is it's it's in our bylaws, it's in our workflows. This is stuff we have to report to the federal government or state government on. So yeah, I think, sorry, but yeah.
But Eric, didn't hardly answer what you're talking about there, where you were saying that the beauty of the integrated
Yes.
So it's not individual-based providers, it's team-based care. And so what you're describing there gets to what we were talking about earlier. So when you bring that up with your primary care provider, and they're like, great, hey, fantastic, let me bring in a colleague.
Yeah.
And so it's at that point then that they can engage that BHC into that appointment. They can do a warm handoff in that point and do that, and then the primary care provider can carry on with their day, and that appointment has happened. And so
And circle back around, right? So the behavioralist does their assessment, and then they meet, because they're a team, and they say, hey, this patient's presenting as if they have major depressive disorder. You tell a medical provider what it is, they know how to treat that, right? It's figuring out what it is. That's the greatest benefit of integration.
because I think you named just in a typical primary care setting, part of the difficulty in bringing that up, the provider bringing that up is if somebody might say something, and then what do you do with it? And so I think that's the difference between co-located services and integrated services.
Absolutely right.
Let me just add a bit of a question to that. What is the role here of tablets and electronic screening tools?
So we have implemented exactly what you're describing. And locations where I can't put a therapist for a variety of reasons, or maybe we already have one, but we need a secondary FTE to help support walk-in care, because we do walk-in care in a bunch of locations, 7 to 7, 7 days a week, right? Which happens outside of normal hours. So iPad availability. So then a behavioral health consultant in our Pittsburgh clinic could be available for a behavioral health complaint that walks into the walk-in care in Fort Scott. And so I think technology is a great equalizer when we look at overall cost. And if we're utilizing technology through telehealth or e-visits or other formats, it's a great way to spread the providers that we're so incredibly short on to make a bigger clinical difference.
I want to address one of the barriers for primary care is that we're a rural health clinic. So our providers need to see 16 to 18 patients a day to avoid getting penalized by Medicare. And a couple of years ago, that was a $50,000 fine, is what that was. So as the administrator, I kind of hound them, roll them over, but we're not doing a service to our patients by doing that.
Absolutely.
So it's a no-win situation when it comes to that.
I think it is such an important point that you raised, because I think you just described the reality of primary care for most people, which is quick 15-minute increments in and out.
One symptom. You can only talk about one thing.
Maybe you're lucky to get your health needs met in that time, much less your behavioral health needs. And I think it's an important point because as easy it is for someone like me to say, oh, we need to bring behavioral health into primary care, I think we have larger issues of the value we place on primary care. And are we respecting and supporting the role of those clinicians? I totally agree about teams, like that should be there, but I think there are underlying issues about payment. And are the payments aligning with our expectations and hopes of primary care? And are we supporting that particular part of the workforce sufficiently?
Especially
and in non-integrated settings, as the primary care provider, we sometimes hear that they don't want to ask the question because if they get the answer, they then, where am I going to send this patient? I have no place to send the patient. I'm sorry, Eric?
No, I was just going to add, we're having this conversation, of course, my mind thinks from the FQ perspective, but what about all the standalone rural primary care docs and nurse practitioners out there? Like reimbursement mechanisms for behavioral health integration have got to be an incredible limiting factor for those groups.
We have a question up here.
So regarding workforce development, being a young adult myself entering my career, Kansas ranks 5th as the worst state at retaining college graduates, and the statistics just worsen when you look at psych or behavioral health students. So what can Kansas do to really incentivize these students staying and practicing in rural
Eric's
Kansas?
jumping out
Girl,
of his seat.
that's like a slow pitch right down the middle for me. Southeast Kansas, our number one export is our children. Number one export is our children. Because they get jobs and then, or they get educated, they go to universities, which we have a wonderful university in Pittsburgh, and then they leave for better paying jobs. Part of that looks at specifically thinking social work, licensed professional counselors, payment parity, right? You can be an LMSW and you're going to make more than your counterpart as an LPC, despite very similar trainings and still having a master's degree. And I say similar, there are social workers in the room. I don't mean that it's exactly the same, but you guys can practice therapy and do an incredible job and you're all well trained. The challenge is I can't hire any entry-level staff due to fee-for-service reimbursement. And at Community Health Center, we make a commitment to treat everybody regardless of their ability to pay, and we have never turned anybody over to collections, just like we've never turned anybody away from service. So we have a lot of uncompensated care, which we are glad to do, and we should be doing as a federally qualified healthcare center, and some of that is offset through a certain type of reimbursement through our friends at the state. But how do we fix that? We empower organizations through potentially expanding PPS reimbursement for FQs that are willing to help you get your clinical licensure. And then you practice wherever you want, because you can practice independently and you're not under the thumb of any organization, because you could walk out of that organization and open your own clinic down the road. And that's what we need. So, yeah.
For our rural communities, that's really a challenge. I want to keep, I need some wood because this is going to bite me. For the last 3 years, our retention rate has been 99.4%. We have turnover, but we have waiting lists for people who want to come work for our organization.
That's incredible.
Yeah. Except for social workers. But that's a really hard job where you grew up.
Yeah.
That's really hard where you grew up. And the people that you're caring for were the people that you looked up to. So we do recruit from out of the community.
Sure.
And then how do you keep them? Because that's not where their family is. That's not where their friends are. So that's a huge challenge. You're exactly right. Yeah, and something that we work on every single day.
Yes.
So, so three things we've been working on in Kansas over the last 5 years to try to improve our workforce retention for students is we've been trying to increase the Medicaid reimbursement rates, right? Because if we can increase reimbursement rates, we
For
can...
primary care?
Well, for social work was
for
what I was
social work,
thinking about.
okay.
But because what we're trying to do is find ways to, allow for better paid salaries, right? So that people are more willing to stay here and do this work. Second leg of that stool, right, is that we have implemented CCBHCs. That is a huge change in how the CMHC system is able to reimburse their staff. So this morning when we were in Douglas County, you heard the Douglas County folks say that they were able to increase their salaries by 20% in 1 year when they got their CCBHC status. And then the third leg we've already talked about on this stage, which is Medicaid expansion. If we can get Medicaid expansion to happen here in Kansas, that'll have a huge impact on the amount of youth that finish school in Kansas and stay in Kansas.
There is some evidence, folks, help me out here, but I believe there is some evidence to show that people who either grew up in an area have a better chance of practicing in that area, or people who train in that area have a greater chance of practicing in that area. We know there are some programs such as loan forgiveness that draw providers to an area for a certain amount of committed time. There are a couple of states that have programs that for some providers, and here I just think we're talking about physicians, to provide a tax credit to keep them, a modest tax credit, to keep them in that area beyond the time when they're, after they're finished with their loan forgiveness commitment. But what can we do? Do we need to be training people in the areas where we need them to practice? Is there a problem with where we are training people? What
Well-
areas we're training people?
Well, I think in Kansas anyway, like we've been very attentive to that as a concern, right? So we have a very strong community college disbursement around the state. We have 2+2 programs that allow you to go to those community colleges for 2 years, transfer all of your credits to a 4-year school. We have a good, we have fewer state schools, but the state schools that we have are spread out and they are accessible and they do have good programs. And I feel like, for the most part, our university system is pretty solid. I think the problem is that once you finish the university system, your opportunity to make more money outside of this state is greater than your ability to make money inside this state. And that's where I think we lose a lot of youth.
CHC, we partnered with KU to offer an MDDO residency program. To your point, 50% of physicians live within 100 miles of where they completed their residency. And so a big recruitment point. I'm not sure if it was the Mental Health Association that brought this forward in this year's legislative cycle or not, but very solid bill that looked at state funding to help support residency of psychiatrists in Kansas, because the more psychiatrists we can get here doing the residency, the higher the probability in which we can keep them. But also think of obstetrics. Obstetrics, huge shortage in Kansas, especially in rural Kansas. So.
Okay, question here?
Sorry, so mine really is kind of piggybacking on some of the comments that have already been made. So we've done some work with Comprehensive Primary Care Plus program out of Kansas City, and part of that program was piloting alternative payment models in primary care offices to provide really what looked like a capitated payment per patient per month to provide the entirety of that patient's primary care services, including integrated behavioral health. And so there was a lot of success with that payment model, but then it just ended. And so maybe this is kind of an ask. I know that the state can only do so much, but when, or is there any hope for moving away from the fee-for-service model that I think a lot of you have referenced as being problematic with fully integrated behavioral health and primary care? And maybe that's just an ask to carry that back, more so than an answer today.
You have my vote.
I think there is interest in doing that. I think the question is, what are the mechanisms, right? And where do those mechanisms lie? Are they with Medicare? Are they with Medicaid? Something that a state Medicaid program could do, I believe, is move to an integrated capitated payment.
There's got to be value as well, though, right? Because then you open this door to every person you see, you get a set fee, and then it can just become astronomical. So I think value, evidence-based practices, outcomes reporting. Outcomes
just
reporting.
to add to that, I think measurement.
Yeah.
We need to measure integration. We need to measure how people are getting their services and link that to payment, rather than just relying on payments alone as the vehicle.
Yeah, and the task force that Bipartisan Policy Center went through and that Vikki participated in, the task force came to the conclusion that the easiest places for us to do integration, at least to start, were with some of these value-based or risk-bearing models such as Medicaid managed care organizations, Medicare accountable care organizations, and Medicare Advantage, because they are bearing risk and have the infrastructure and the ability to really put this kind of a system in place the easiest.
So Sarah, I think you got to have a good point, but I'm going to speak on behalf of critical access hospitals in the world. That's a huge risk.
Yeah.
That is a huge risk, and administratively, that would be a tough sell.
That was the value of the Comprehensive Primary Care Plus, is it was zero risk for those pilots.
Right.
Bill, do you have a question, or are you wrapping us up?
No, I have a question.
Oh, okay. Then this is our last question.
Okay. And this is a little bit off the wall. Andy, you've said a number of times here about Medicaid expansion. Vikki, I think in her earlier comments, indicated one of the best things we could do for behavioral health in Kansas is to have Medicaid expansion. I'm sitting here looking at Senator Dole behind you. I began my career working with Senator Dole and George McGovern, if you can believe it, on something called the food stamp program, now the SNAP program. A strong believer in taking that step. I wonder today what he would say. But what is it about the and this is, maybe you don't want to go here. What is it about the politics of this which is that Kansas will not expand Medicaid? Given,
Yeah, I was gonna say I don't know if that's a fair question, but I mean, basically, in Kansas, we have right now we've got a Democratic governor and we've got a Republican Senate, and our Republican Senate will not listen to Medicaid expansion or consider Medicaid expansion while we have a Democratic governor. So
a Republican governor, would it make any difference?
it probably would.
Okay, is there any final word from the panel? If there was one thing you could do that you could ask for from either your state government or from the federal government to make integration easier in your state, what would it be? Andy?
Oh, can we start and then go this way?
Okay.
I'm still sweating.
Vikki?
I felt the heat.
You just took the expansion question. We'll cut you some slack here.
I think both at the state and the federal level, building into insurance programs active standards and measurement for integration. So Medicaid is run in Kansas and in most states through managed care plans. Having integration contracting standards, having measurement over time, managed care is the way that Kansas and many, many other states drive behavior. And so I think we've spent a lot of time today talking about the barriers at the practice level. If we're able to bump it up a little bit and set some expectations from the federal and the state level around integration, I think that could be a powerful driver of change.
And that starts with defining what behavioral health integration is, what the aspects of behavioral integration, what it looks like, because we have no agreed to shared definition for what this thing looks like. Our definition is we think we should meet people where they are. It's going to look very different in different programs. Anyway.
Yeah, for our facility, the barrier is staff. That's the only barrier. I have 4% Medicaid rate. So getting the private payers on board is sometimes a challenge because they all want to do their own with telehealth. They've got their own vehicles. So it's really staffing for me.
Staffing.
Outcomes. We're spending a lot of money. What are the outcomes? And I think making that transparent to where we can see it, to where we can say what we're investing matters. Because taxpayers' dollars finite. And SAMHSA published some really good stuff in the world of behavioral health this past month in March with very well-defined outcomes and reporting measures. And so outcomes, I think, is a big thing, and transparency.
Andy, you get the final word.
So I think the biggest and most important one is collaboration. I think we have to work together, both at the state agency level and with our federal agency partners, to really kind of set a standard and say this is the goal that we have, and this is the progress and milestones we want to make to get to that goal. And I think once we're able to establish that, providers will be able to embrace that vision and help us get there.
Okay. Please join me in thanking this incredible panel for a great discussion.